So as economists, we like to think of health as a form of human capital. This is an asset that helps you be more productive and generate more income. And in particular in developing countries where a lot of the economic activity is brown-based and requires strength, being unhealthy makes it particularly harder to generate income. Obviously, health is also just something that we care about for itself. Life is much more pleasant if you are healthy, and it's definitely extremely better not to have to see through the suffering of your children or even their death. Okay? So health is important, it matters, but it's lacking in many parts of the world still. So this is just one way to show that. This is under 5 mortality throughout the world, and you can see that the darker shaded colors mean more mortality as of 2015, so when the Millennium Development Goals were supposed to be reached. And mostly in Sub-Saharan Africa and in parts of Asia, we are still quite off the mark. Okay. So this is just the tip of the iceberg. There are many other ways through which the disease burden is still very important in developing countries. Now, if you look at the take-up of preventative health investments that exist, such as bednets or chlorine, diluted chlorine to treat your water, or water filters, or hygienic latrine slabs, at full price, the demand for these products seems to be quite low. Okay, so there's a number of studies that estimate that less than 20%, and that's kind of a generous estimate, less than 20% of people purchase these products at full price. Okay? So the question then is, why do we see low investment in preventive health? Why don't we see more take-up of this thing that could help alleviate this big health burden? And so the first question you may ask is, well, maybe simply people, don't think that the returns are so high because a lot of these diseases are infectious, and so maybe if I just protect myself, I'm still going to get the stuff from you, so what's the point? And indeed, that would explain why, for example, investments in deworming may be very low, because there the social returns are much higher than the private returns. Okay. But often, the returns to certain of these technologies are extremely high for the private individuals. Okay? So sleeping under a bednet really reduces the likelihood that you get malaria, or treating your water really reduces the likelihood that waterborne diseases affect your households. So then the question is, why don't we see more of that? And so, I come from France, where when you walk around the street in Paris, you still see a lot of people smoke, and you ask yourself, why is that? And I think the answer is that maybe people don't value their health that much, or at least in the future. Okay, so you may tell yourself, maybe in European countries it's the same issue, that people just don't value their health that much, and that's why they don't buy these prevention products. I think that's an hypothesis that we can easily dispose of, because if you look at what people seem to be spending money on, treatment of diseases seem to be a very important part of their budgets. Okay, so people spend a lot of money on treatment, and often they go into debt in order to treat an illness when it strikes. They work extra hours, very long hours. They can take on very risky jobs in order to be able to make sure that they get the right treatment to their children or to themselves. Okay. So people value their health. Maybe they do not know how well all these preventive products work, and sometimes indeed they don't. But sometimes they do, and they still don't buy them. And so then the question, if you just ask them, why don't you buy these things? Well, they tell you, it's very simple. I just don't have enough money. Okay. So you can ask this question all around, and that's going to be the answer that you get. And in that case, what seems to be an obvious solution would be to just reduce the price. Okay. So subsidizing preventative health products may be important to make sure that more people have access to them. Now, there is a number of rationales in economic theory for why this would be a good idea. So the first one is that because most of these diseases are infectious and communicable, it means that by protecting myself, I also protect you. Okay? And so it makes sense for me to be subsidized in order for me to adopt this behavior that's good for everyone. Okay? So think, for example, about a very young worker working in a retirement home. Maybe for that worker, getting a flu vaccine has really very little private returns because maybe he or she can easily go through the flu without being too bothered. But obviously, if she gets the flu and then she passes it on to some of the elderly folks around our workplace, that may be really bad for them. Okay? So then who should pay for the cost of that flu vaccine for that worker? Well, that person shouldn't pay herself because she's not the one accruing all the benefits. It's really all the elderly folks around that are going to benefit from her being protected, and so her vaccine should be subsidized. So that intuition carries through for many other situations where you're trying to reduce the burden of infectious diseases. Okay? So in economics, we call this a public good. Limiting the spread of infectious diseases is a public good. Now, another argument that you can make is that because we have some strong evidence that being healthier early in life means that you're going to be more productive throughout your life, if we invest today in making children healthier throughout their lives, they will be generating more income, and then we can possibly tax them enough throughout their life to recoup the cost of this investment. Okay, and that may be a high return on investment. Now, for the health impacts of subsidizing these health products to be realized, we need the beneficiaries of subsidized inputs and products to put them to appropriate use. Okay? And so when you think about a vaccine, that's trivial. You put an antibody in my vein, I'm not going to take it out. I'm going to be protected. I don't have to do anything. Okay? But for many other preventatives, it's not the case that I just have to wait for someone to put something in my blood and then I'm safe. Okay? I have to actively, proactively every day take on an action. I have to set up the bednets over my bed. I have to put on a condom before I have sex. I have to put my water through the water filter. I have to put the diluted chlorine inside my jerry can over and over and over again. Okay? These are not things that we have to do. We only have to brush our teeth, okay? Pretty much. And I guess use condoms. But most of these other things we don't have to do. But in environments where the water is not clean and there is malaria and all these other things, people would have to do these behaviors over and over. And so it's a reasonable question to ask whether they are going to do it. Okay? And the concern is that if you make it too cheap for people, so they don't really have to pay attention to the fact that they are getting these things. They don't have to pay for it. Maybe they are not going to be able to. They are not going to be willing to put the effort that's needed to use these tools on a daily basis and to reap the health impacts from it. Okay, so that speaks to this bigger debate of how much to subsidize these products. And on the cost-sharing side, people who say, no, it's important to charge people. There's this idea that, oops, I'm going the wrong way. That indeed, prices. We think of prices in economics as being an allocation mechanism. Okay, the person who is willing to pay more for a product, presumably the person who reaps higher return from that product. Okay. That's why, when Apple starts with a new iPhone, they charge it very, very high, $800. They know that only people who love Apple are going to buy this, and then they're only going to spread good information about it. So you want to select people who really want the product. If you want to do that, you want to charge some price. Now, on the other side, you may say, well, but we've just told you people don't have much money. Okay, so if we charge a price that's too high, then we may screen out a whole bunch of people who really would like to have the product, but they are just too poor. Okay, and if the poor are those who are facing the biggest health burden, then it would be unfortunate that they don't get to access this product. Okay. Another argument against subsidizing too much, especially against going all the way to free distribution, is the idea that maybe create an expectation that things are going to be free forever if you ever make them free. Okay, so it's this idea that it's like myself with respect to the New York Times online content. It was free, and then they started charging. I was like, what? it should be free. And it took me 10 years to agree to pay the fee, which was great for my productivity. But recently I had to give up, and reading the news was very important. So now I'm paying for online content. But so if people are like me and they anchor and they're like, oh, this was free, it should be free forever, then subsidizing something for a short while to bring people over the hump may be affecting your ability to later on charge them for health products. On the flip side, you could say, well, we are used to free trials. When a new firm comes up with a new product and they want people to know about it, it's not uncommon for them to do free trials or to say, you can win this thing if you fill, this little survey or something like that. And the idea there is that if I get a chance to try something out and experience how well it is, then it's going to increase my valuation for it. If I don't have much money, it's going to be hard for me to take the risk to invest in something I don't know if it works so well. Okay, so I need to have a chance to try it out when it's super, super cheap for me to learn. And the final argument against subsidizing too much is the idea that, well, it's more expensive, obviously. The greater the subsidy, the more money it costs the government or whomever is subsidizing the product. Okay? So if you can recoup some of the costs from the beneficiaries, it's just cheaper, and maybe you can do this for longer. On the flip side, you could say, well, if a government goes to a household and says, look, here's this product I'm giving to you for free because I think it's really important, there may be some signaling value there. There may be some information that's being implicitly provided by knowing that the government is putting its money where its mouth is. That may be a very strong endorsement that may matter for the household's perceived returns to putting the effort to daily using this product. Okay. So ultimately, to kind of settle this debate, we need to answer 4 questions. The first one is, how price sensitive is demand among those who need the product the most? So I've already hinted at the fact that it's likely to be quite high, but we'll try to be a bit more precise on that. And then if we find that indeed, demand is very price sensitive, which means that, as the price goes away from zero, demand drops quite rapidly. Is there anything that we can do to kind of lift that demand curve? Okay? Is there anything that we can do through marketing or information to make people less price sensitive, to make them pay more for these products? And if we cannot, then we have to ask ourselves, okay, well, fine, we may need to subsidize heavily, we may need to make it all the way to free. Do we then face this issue that there's going to be a lot of unuse, a lot of wastage, because recipients of free goods are not going to put it to good use? And even if they do, we won't be totally sure of what to do, because there will still be this question of the dynamic effects of this. In the long run, if people are not willing to pay for products that they once were free, then we may want to think twice about today's subsidy level to avoid having this downstream negative effects. So what I'll be talking about today is the fact that in the last 10 years, a number of us at JPAL have been doing these pricing experiments designed to answer some of these questions. So what do I mean by a pricing experiment? You want to expose people to different prices and compare the resulting take-up and usage and ideally health outcomes across people who face different prices. Okay? And when you expose people to different prices, you want to make this variation random, so that when you see differences between people who are exposed to a low price versus a high price, you know that this difference doesn't come from them, some intrinsic features of their lives or their preferences or anything. It only comes from the fact that they were exposed to a different price. Okay, they had access to the product at a different price. Okay, so that's what we're going to get out of doing these randomized trials of different prices. And so this is the result of a number of studies that have been done in the last 10 years, showing for a number of products on the x-axis the price in homogenized in 2009 US dollars. Okay, so this is the price that households face. So they were randomized into one of these prices. There are many different studies in different contexts, different countries, different products. The actual products concerned have different, full prices. But in all these cases, let's take, for example, this one. So this is water filters in Ghana. It's a study by Jim Berry and co-authors that was done around 2009. And so they can look at the share of people who are going to take the product when the price is just below 2 versus 3 versus above 4. And what this tells you is that as the price goes up, the demand goes down. Okay, so it's not like they tried possibly all prices in between, but so we extrapolate and draw these lines. But the key findings is that 90% of people are going to pay just below $2 for this. But when you just increase the price to 3, it drops to just below 50%, and you further increase the price, and now you're at 25%. Now that the actual full price cost of this product is $15. Okay, so when you're at close to $6, it's still more than a 50% subsidy. It's like something like a 70% subsidy, and yet you have less than 10% of people who are going to buy it. That's how you want to read this graph. So we've done this for water filters. There's something, this like plastic latrine slabs or like hygienic slabs for latrines. Some of my own work that I will be talking about more in the next minutes is bed nets to protect from malaria. This is a study that was done with households that got vouchers that they could redeem to get bed nets at different price points. This is another study with bed nets, but this time with pregnant women who they walked into the prenatal clinic, had a chance to buy the product. They didn't have very much cash on hand. So here you can see that if it's free, everybody takes it. If it's 10 cents, 90% of people take it. But if it's just 50 cents, less than 40% of people take it. So overall, the flavor of this figure is that the main finding for those of you who've done Economics 101 is not that these things are sloping down, because that's trivial. As price goes up, demand goes down. Okay, so that's not the main takeaway. The main takeaway is that the returns for these products are estimated to be much higher than these various price points here, and yet it seems to be difficult for households to put in the money to get these things. Okay, so given this, the question number 2 is, well, is there anything we can do to kind of like push up this right-hand side of the figure? Can we make people be willing to pay more? Okay, and so in one of the studies, this one with bed nets, I asked myself, well, if I were Coca-Cola, what would I do? Okay, because everywhere you go in the world, you can find some Coke, and you find people buy Coke. Okay, so maybe there are some tips from the marketing literature that we can use to think through how to increase people's willingness to pay for stuff like bed nets, and not just Coke. So I did a bunch of stuff, and essentially people were randomized into these price groups. I've now punched the prices, and this is in Kenyan shillings, so it's not the same numbers as you saw before, but it's the same underlying data. But in addition to randomizing people into different price groups, I also, just before giving them the voucher that they could redeem at leisure over the next 3 months, I also randomized these households into different kind of like mini interventions. Okay, so one of them was there was kind of like a marketing pitch that was done. Either there was no pitch, or there was something that was focused on the having them think the burden of malaria that they were facing. So it was a pretty hardcore module where respondents had to think through the deaths that they had experienced in their own household, if any, due to malaria, the community around them, counting the number of people who had died, and then thinking about the suffering that goes along with that, and in addition to the suffering from just the morbidity, in addition to the mortality. Okay, that was just like making people think through all of this at the same time as they were holding on to this voucher that they could then redeem. And another framing for this speech was to walk them through the financial burden. So then how much have you spent on malaria treatment in the last year, adding that up, and then directly comparing that to the cost of the bed net. Okay? So one was kind of like making the fact very salient that redeeming the voucher and getting the bed net could decrease the suffering that goes on. The other one was making it very salient that it's a good investment to buy prevention, because you can quickly recoup in saved treatment costs what you've invested. none of these things matter. Okay, what this shows you is that the demand curve, irrespective of which pitch you got, looks identical. Okay, and this is in part because people kind of like already know this stuff. You don't need to tell people, tell me, whether you have a child who died of malaria for them to know that they have a child who died of malaria. So this whole salience, it's very at the top of their mind already, and this makes no difference. Okay, just telling them makes no difference. This other one is the commitment intervention. It's called the foot in the door technique. And it's asking people after they get the voucher, you say, oh, so are you going to redeem this voucher? When? Once you have it, who is going to be sleeping under the bed net? And that's called the foot in the door technique because it's making people think through the motions that they are going to take and think through the life that they will have once they have taken this motion. Okay? So it's like making people make a plan that's so concrete that then it's going to be costly for them not to follow through with their plan because they've already kind of like started, imagining all the great stuff that's going to happen in the follow through the plan. Okay, so we asked them, are you going to redeem the voucher? 95% of people said yes. Who's going to sleep on our bed net? So and so. But again, no effect whatsoever on the redemption rate of the coupons. Okay. Final one. Some people have argued that maybe there's a conflict within the household. Maybe the issue is that, as we all know, women are great. They are the ones who are going to do the investments in health, whereas the guys only care about booze. That's kind of like a stereotype that I don't adhere to, but that's often heard among practitioners and policymakers in developing countries. While here, I randomize whether the vouchers and all of these things, if any, were done with the female head of the household or the male head of the household, or both of them jointly, thinking that maybe we can get them to talk with each other and agree right in front of us. None of that mattered either. Okay? So the takeaway from this slide is that you can try to do a whole bunch of stuff, and maybe I was not creative enough and I didn't think of more things that you could do, but my takeaway is that really it's very hard to move this demand curve. People are sensitive to prices, and very much so. It's not because they lack information or things are not salient or that they need to agree in the household. It's really that they don't seem to have the money. Okay? So given this, and this is a result that others have found. So, for example, Meredith et al. In a paper published in the JD in 2013 have shown similar results for soap and vitamins. If you do workshops to explain to people the benefits of these things, it doesn't help increase demand at higher prices. And Kramer and Miguel, looking at deworming, also found that health information workshops did not increase take-up at non-zero prices. So now the next question is, okay, so clearly demand is not very high at high prices, so we need to subsidize quite a bit. Are people going to use products to the same extent if they don't have to pay much for it? So if we don't force people to prove to us that they really care by having to pay something, do they care enough to use a product? And for that, not all of the studies that I showed you here have actually been able to follow through and look at usage. Okay? That requires an extra step. That requires following up after 3 months or after a year, going to the households, looking what they do. That requires additional resources. Many of our research studies may not have those resources. But for those who did, on the whole, we find that irrespective of the price you end up paying, the usage is kind of like the same. Okay, it varies a bit, but on the whole, there is no relationship between the price you paid and whether you use it, which is extremely surprising because remember, people are highly selected, okay, in the sense that there are very few people who pay $2 or more for these things. So the very few people who pay $2 or more for these things, it's almost surprising that they are not more likely to use a product than the people who did not. Okay? What this tells you is that the selection that you get out of charging is not the one that you really want because it's not selecting people who are more likely to use. It's simply selecting people who essentially are better off. Okay? Now you may say, okay, fine, they all use the products equally, but imagine that those who get it when it's free, they use it because it looks nice or what have you, but maybe they don't actually face as much of a health burden, so maybe the returns for them are not that high. So here what we are asking the marginal users, and here in economics what we call the marginal users are those who are induced to use the product thanks to the subsidy. Do they have equally higher returns? And so another way to ask the question, maybe more simply, is or if we look at the health burden that households face, is it equally high for those who only use the product when it's made free or very cheap, okay? And if not, imagine, for example, that when you bring bednets, the price of bednets down to 0, all the extra people that start using it live in areas where there is no malaria, and they are only using the bednet because it protects them from flies, and flies are a pain when you sleep, okay? Then you wouldn't get much of the health benefits, and so why would you want to subsidize those folks, okay? So it's important to look at who are the people who are induced to use more when you subsidize, okay? And so we can do this as long as we have some markers of the disease burden that people face, and that can be tricky. But for malaria burden, for example, we can look at the rate of anemia at baseline, which is a marker for the malaria burden, or we can look at the rate of diarrhea at baseline, which is a marker for waterborne diseases. And so if I do this, for example, in a study with Jessica Cohen, looking at the take-up of bednets among pregnant women, this was also one of the studies on the graph before. As the share of people who get a bednet and use it is over 60% when it's free. That's usage after 3 months, and just around 10% at 40 shillings. But if I look at the likelihood that they have anemia at baseline, is the same across all price points, okay? Which means like good news in a sense, because those who get it when it's free are equally affected by the anemia and malaria burden than those who don't, okay? And it seems like there is somewhat of a positive slope here, but remember there are extremely few observations, very few people who buy the bednets at this price, and so this is very wide confidence interval, that's what these bars are, and this says that we cannot actually say that this number is greater than this number. From a statistical perspective, they are equal to each other. Okay, we can do this also for, let's say, chlorine. So this is a study I'm going to talk a little bit more about in a minute. This is when the chlorine to treat your water is free. About 38% of households use it. So you can actually find chlorine in the water when you go to the house and test the water for chlorine residual. And this goes down to 10% when the price is 10 shillings, which is a 50% subsidy. But again, those who get it when it's free are not less likely to have had diarrhea at baseline. So this is saying that the likely health impacts of getting all these extra people to use the products when you make it free may be high, because they are equally affected to start with. Okay. So this is all well and good. So far we've shown that there's very sensitive price, very price-sensitive demands, and it's very hard to shift. And so we may need to subsidize heavily, and the good news is that people do put products that they get for free or very cheap to good use. Although you may have noticed on the previous graph that for chlorine, usage when it's delivered for free at home is less than 50%. Okay, so this is this one here. This is a case where people just got the free chlorine, everybody was given it, and then when we go to their homes within a few months, we find that less than 40% actually have chlorine residual in their water. Okay. And we give them a whole year supply. So it's not like they are hoarding it for later. Okay? So in that case, you face a stark trade-off, okay? Because if you don't make it free and you charge like a price, like 10 shillings, which is a 50% subsidy, only 10% of households have water that's treated. If you make it free, you increase that to close to 40%. So that's a massive increase, okay? So if you value the health and life of the children in these households, this extra 28 percentage points of households that now get the treated water, you really want to do the free distribution. But it comes at a large cost, in part because you end up giving chlorine to a whole bunch of people here from 38% to 100% who get it when it's free, but they don't seem to be using it. Okay? So the question is, when we face such a product where some people don't seem to be interested in it even when it's free, can we design a subsidy that gets us these gains without the cost of giving it to people who are not going to use it? So can we target better? We know we still have to make it free. We know we can't really use price to target. We know that if we try to use willingness to pay as an indicator of whether you're interested, we are not going to really get where we want. So what can we do? Okay. So here, we can think of something that we've, kind of like, the literature has called an ordeal mechanism, but as researchers, we decided to call it a micro-ordeal, because it's really not too much of an ordeal. Like, economists have this habit to come up with titles for things or like names for things that really are, very offensive to everybody else and an economist. So we're hoping that micro-ordeal didn't sound so bad, okay? Essentially, what we are saying is that the idea of having people pay a price is that by showing that they're willing to pay, you learn something about how much they care. And I've told you it doesn't work so much because people really are short of money. So can we make them signal for some other way that they really care, okay? And so, for example, we could say, well, let's make them queue for 10 hours, okay? Well, that's maybe not a micro-ordeal. That may be a macro-ordeal, okay? So we, you want to think of like a small hassle that people would have to go through to signal that they care, okay? And that would be a way to screen, not on money, okay? And so really, you want to do that in a way that doesn't screen out too many of the people who would use the product otherwise. And so in this study that we published in Science recently with collaborators, we compared different ways of setting up a subsidy for chlorine. So we had a 50% subsidy for chlorine that you saw on the previous graph. We had 100% subsidy with free delivery. And then we had this intermediate thing, which was 100% subsidy, but with this micro-ordeal. And practically, it's much simpler than it sounds. We just gave people coupons, 12 coupons. Each one of them can be redeemed for a given month. Okay, so you have your January coupon and your February coupon and your March coupon and so on. Okay, and so the ordeal here, the little hassle that you have to go through to get your free chlorine is just to go redeem your coupon. Obviously, if the place where you can redeem your coupon is very far from your home, this is, a significant ordeal. Okay, maybe it's very costly for you to get there if you have never any reason to ever go there. That's a huge cost. So maybe that defeats the purpose. But if the coupon can be redeemed locally, and what it requires is for you to keep track of your coupons, think about chlorination and go redeem it, then that could work quite well, because people who presumably have no interest in treating their water, they are not going to bother to actually keep track of their coupons and go redeem them. Okay? So what we did is that when we looked at redemption of coupons, we find that the first coupon that people get, they get very excited. Many of them go redeem it. But it seems like a bunch of them learn that they don't really like this product. For those of you who've done some hiking, you know about water tablets, chlorine tablets that you put in the water that you fetch from wherever. So it does leave somewhat of a test to the water. Some folks just are not interested in that. Some folks may just have clean water at their source. They may have a water filter. They may have some other ways to clean their water. So they're just not interested in this product. And so for them, the redemption rate just falls, and it kind of tapers off. Over time, it seems like there is a fall off. Okay, so maybe people start misplacing the coupons or something like that. But it seems like there is a good chunk of households, just around 40%, who keep redeeming for a while. Okay, so then the question is, are these the very people who were using the product when it was free? And so we can look for that by plotting the likelihood that indeed we found residual chlorine in your water when you went to your house. And we find that it's essentially identical between the free coupons group and the free delivery group. So this is really good news, because it means that you don't have to give all this free chlorine to all these people who are not going to use it. You can just give them coupons, and then they're going to self-select into using the coupons only if they're going to use the product. Okay? And again, if we look at whether those who redeem the coupons and use the treatment, the chlorine, face an equally high disease burden, it is the case. Okay, so that's where you get the selection you want exactly. Okay. Now, a word of caution: we were extremely lucky to calibrate the ordeal exactly right so that we get this. Okay, I think it was like pure luck. In practice, you want to be very careful that your ordeal is commensurate with what's going on. So an example where micro-ordeals don't work so well is if, for example, everybody has a very high value for whatever you're subsidizing, even overvalue it. So for example, in some work with Jessica Cohen and Simon Schenner, we give people vouchers for subsidized antimalarials. And so for that, you have to go to the shop to redeem antimalarial. So there is this cost of having to go redeem your coupon. It turns out we find that many, many people who don't have malaria nevertheless buy anti-malarials. That's because they don't know they don't have malaria. They think they may have malaria. They don't have a good way of knowing. We were able to test them exposed to realize they did not have malaria. But this is the case where if people have no information about their likely illness and they really value the preventive treatment aspect, making them go through the ordeal having to go to the store is not going to help with selection whatsoever. Okay? So it's not going to be always helping you with selection to make people redeem stuff. And alternatively, sometimes what may seem to you like a small ordeal can be like a massive hassle. Okay? So this is an example of like an ordeal for coupons in some work that we've done in some pilot work where we give adolescents vouchers for condoms that they could redeem at the local store. And we found very, very few people redeem the vouchers. For girls, it was just 1%. For boys, it was 15%. Whereas later on, we went to their homes and said, do you want, we're a little bit heavy-handed, so we bought 150 condoms at once. Said, do you want 150 condoms? So many of them are like, well, my mom is going to kill me if she finds them, so they only took some of them. But everybody took at least some. And so you can say, well, this tells us that there is a lot of demand for condoms, but if you ask people to go redeem a voucher, they don't do that. And why? Because it may look like a micro ordeal to you, but actually it's not. Because going to a shop in your neighborhood, facing the shopkeepers who is like your uncle or a friend of your mother and say, I'd like to buy condoms, please, is much harder than it looks, especially if you're a teenager. Okay? So that's all to say that calibrating the ordeal is very important. It can backfire. I'm close to out of time, so let me try to wrap up quickly. Another way to target chlorine to those who are going to use it would be to put a chlorine dispenser near the water source. This is something that may be worth it when you have enough population density. You just put chlorine in a dispenser right by where people fetch their water, and that's where it's cheaper because you don't have to just give free chlorine to everybody not knowing who is going to use it. You know that it's like in a soap dispenser in the bathroom, people who don't want to wash their hands, they're not going to press the button and make the soap fall on the floor to waste it, okay? And it has the added advantage of it's right there, visible. It can increase salience. It can also increase social learning because you see, this, highly educated woman putting chlorine in her water after she fetches water. Maybe you think, oh, maybe I should do that too. And so that has been shown to increase coverage of chlorine by quite a bit by work that Michael Kramer and others have done. Okay. So now the last, I still have one question that I needed to answer. I'll be very quick. If you make this thing free now, are you tying your hands forever? So here the evidence is not very, very many. There's one study that I have done, and there's some stuff that has been done more recently that's still being finished up. But what I found in one of my bednet studies was I went back after a year, and people had been initially in phase 1 randomized into prices that went all the way from free to 50% subsidy. After a year, I came back, and now everybody had to pay $2.30 if they wanted one. Okay? And I found that people who had gotten a free one the first time around or a very cheap one the first one around, so if your initial price was somewhere here, you were much more likely to actually buy a second one. Okay? Which means that presumably you've learned that this was a good thing, and that the fact that it was free once in the past doesn't really matter for your willingness to pay. Okay, so far the evidence suggests that we shouldn't be too worried about these dynamic effects of subsidies because it seems like people rather learn about these things rather than learn that it should be free. Okay, so a few additional pieces of evidence. There's, when people get access to credit, it's easier for them to invest in these things. So whether it's investing in piped water in Morocco or bednets in India, also getting access to better saving devices help people. So again, this speaks to the fact that financial constraints is a big deal. There's also the question of whether implementing free subsidies is easy. Maybe you say, okay, fine, we're going to give free bednets to everybody. But then you drop them at the health centers for health centers to give them to pregnant women. Maybe they all end up going to someone else than pregnant women because the health workers are making money off of them. Well, we've looked at that in the context of 3 countries. We don't see much evidence at all of there being extortion or leakage. And so health workers on the whole seem to be willing to distribute these products. And so the key takeaways, and then I'll stop talking, are that screening on willingness to pay, which is what we do all the time when we charge prices for things, seems to be too blunt of a tool for targeting health products to those who need them, especially in areas where people have little income and are credit constrained. So making essential products free can massively increase their coverage, but making them free does not imply it has to be free delivery. Okay, in some contexts, you may want to be a bit creative and give them coupons for them to redeem, or make them go through a small hassle, so that you don't get people who are getting a subsidy but not using. Okay. Now, looking at the policy impact of this, I don't actually feel totally comfortable taking credit for this, but this is showing over time the evolution in the share of people who had access to a bednet in Sub-Saharan Africa, and the decreased incidence of malaria. So clearly there is a very strong relationship between the two, and where I feel somewhat comfortable taking the credit is in the fact that some of the work that we've been doing at JPAL for the last 10 years has helped policymakers push forward the agenda of making free distribution of bednets more likely. Okay? And so there are many countries where there was already some kind of like battle inside the Ministry of Health. Someone was a proponent of free distribution, someone was an opponent of free distribution. And when evidence that's rigorous shows up somewhere on the table, it's easier for one party to convince the others. Okay, so I want you to leave the room thinking about the fact that this is obviously important, but maybe there are some other big ticket items that you want to think about. Okay? So when you think about the most cost-effective way to improve health at scale, you can try to spend a lot of time doing what I did, which is how can we increase the coverage of existing tools and services. But you could also say, well, maybe we should just eradicate malaria. Maybe we should just make sewerage available to everybody and running water. Or maybe we need new and better vaccines and new drugs for a whole bunch of stuff. The international community tends to be very focused on changing individual behavior and this, improving coverage. But my own personal view after 10 years of work on this is that the most important tickets are really thinking about changing the environment. As I said when I started, we don't have to do all that stuff. We don't have to put bed nets over our head. We don't have to treat our water. We can just turn on the tap and drink it. Okay? And in the US, most of the improvements in health over time in the early 20th century have accrued when there were massive improvements in the environment that people face, and massive improvements in the infrastructure and access to clean water in the cities. Okay? And so we can do a whole bunch of stuff in the meantime to kind of like reduce the burden that people face. But the big ticket items are really improving the environment that people face. And so if you become rich and important people, try to eradicate malaria, please. Thank you.